Hello and welcome to Opportunities for Immune Therapy and Prevention. I am Mary Vetting, the Breast Cancer Helpline Manager at SHARE. Before we begin, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 42 years by offering the support of those who have been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. Many of these are specifically for those living with metastatic breast cancer. All services are free of charge to participants. And for more information, please visit our website at sharecancersupport.org. During the presentation, all participants will be muted, but when the presenter finishes speaking, we will open up for questions and answers. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember, the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Our presenter today, Dr. Gatti-Mays, MD, MPH of the National Cancer Institute, is a staff clinician in the Laboratory of Tumor Immunology and Biology and co-director of the clinical trial group. She focuses primarily on immuno-oncology and breast cancer. Her research focuses on the use of cancer vaccines in combination with immunotherapy agents, chemotherapy, small molecules and immune modulators as a way to help the immune system recognize and kill cancer cells. Please join me in welcoming Dr. Gatti-Mays.
Thank you very much for that introduction and for inviting me here to discuss the opportunities for immunotherapy in breast cancer. Let's see. Okay, so first I'm going to start with my disclosures. I have no personal or professional conflicts of interest, no financial disclosures. And importantly, I will discuss investigational non-FDA approved treatment during my presentation, and I'll be sure to identify those items. So this is just an overview in terms of the topics that I'm going to cover over the next few minutes. First, we'll start off with the breast cancer and overview. We'll then discuss how the immune system fights cancer normally, and then talk a little bit about what exactly is immunotherapy. It's a new and interesting field in medicine, and I think is one that many are still trying to understand kind of the basic concepts behind, and so we'll go a little bit into that. And then I'll talk about some experiences with immunotherapy in breast cancer so far, as well as where I see the future of immunotherapy in breast cancer going. So let's start off with just some breast cancer statistics. First of all, breast cancer occurs in women and men, which I think is obviously something that most know, but is important, I think, always to highlight. The 2018 cancer statistics show that women have about one in 8 women have a lifetime chance of developing breast cancer, whereas for men it's about 1 in 1,000. Most breast cancers are invasive as compared to DCIS or carcinoma in situ. Most breast cancers are diagnosed in early stages. And the reason I have the star there is that while many cases are diagnosed in early stages, that despite optimal treatment at this point, that many patients do recur and eventually will develop metastatic disease. Most breast cancers are hormone receptor positive, and the risk of breast cancer increases with age. So if you look here to the figure that I have at the bottom right of the screen, you can see that when women are young, so really kind of before 60, that you can see that DCIS is really more common than invasive. But then the invasive component tends to kind of take hold, and we see more of that in older individuals. And it's just important in terms of thinking about opportunities where we can intervene And again, I'll talk a little bit about this in a few moments when I talk about some potential areas for immunotherapy in breast cancer. Now, there are 4 main subtypes of breast cancer. And I think probably most people have heard of them in terms of hormone receptor positive, HER2 positive, triple negative. The hormone receptor positive is really broken up into what we call luminal A, which tends to be your hormone receptor positive, HER2 negative. These tend to be kind of better behaving breast cancers. They tend to not be quite as aggressive. Whereas the luminal B is generally hormone receptor positive, but it can also be HER2 positive. So these would be your triple positive tumors. But these generally tend to be a little bit more aggressive appearing when we look at them under the microscope. And I think it's important to highlight that while there's 4 main subtypes, that within each subgroup, we do recognize that these are distinct cancers and that there's probably even additional subtypes within these 4 main groups, specifically within triple negative breast cancer. There have been recent studies that have identified within the triple negative breast cancer umbrella, there's probably at least 4 different types of triple negative breast cancer, and maybe even up to 6, looking at the different type of molecular and kind of genetic and gene expressions that we see. And this is important because the breast cancer subtype really relates to the response that we see to therapy. And this would be things like endocrine therapy, chemotherapy, and immunotherapy, but also relates to prognosis. And I think that this is important as a researcher to consider that while these are all breast cancers, that these different subtypes do have different responses, and therefore different therapies may be more appropriate for certain types than others. Now, as many of you know, breast cancer is really approached by a multidisciplinary team. First of all, oncology is an umbrella that's a branch of medicine that specializes in the treatment of cancer. But within breast cancer, we really rely on multiple areas of specialty in oncology in order to appropriately treat a breast cancer. So breast cancer is both treated locally as well as systemically. The local therapy includes things like surgery and radiation, whereas the systemic therapy really consists more of chemotherapy, endocrine therapy, and immunotherapy. I am a medical oncologist, and so I will be speaking mostly about the systemic therapies during this talk. Now, how exactly does the immune system fight cancer? So we know that the immune system is the first line of defense against cancer. And we know this because there have been numerous studies that have found in patients who have a compromised immune system. So these are patients who either have either a solid organ or a bone marrow transplant and are on immunosuppression, patients who have HIV, or patients who are either born with immune deficiencies or acquire other types of immune deficiencies. We know that these patients have a higher risk of cancer than patients who have a competent or fully functional immune system. And it has to do with when we have abnormal cells, the immune system is able to identify them, kind of work their magic, which I'll talk a little bit about in the next slide, and then able to eliminate those abnormal cancer cells or those abnormal precancer cells. And so how exactly does this happen? And this is kind of a simple way of looking at this, but I think that this kind of identifies some of the important components of the way the immune system works, and also will help us tie into why some of these immunotherapies are very promising. So normally immune cells proofread cells within the body, and they can correct the errors. And this is a process called immunoediting. So just like as when you're typing a paper in a Word document, if you're typing quickly and you make some spelling errors, sometimes Word is able to do autocorrect and know kind of what you were anticipating to type. And if it doesn't, it's still able to identify that this word is incorrect and then you're able to go back and manually change it. And this is similar to a process called tumor elimination, where the immune system is able to identify these errors and correct them before they become problematic. However, some cancer cells are very smart, and through a variety of different mechanisms, which I'll briefly talk about in the next slide, they can distract the immune cells and can fatigue the immune cells. Again, they can do this through a variety of mechanisms, but what happens is instead of being able to identify the errors in the sentence or anticipate what the corrections are, the immune cell is not able to do that. And so what happens is as these tumor cells replicate, that you can develop a condition called immune equilibrium, which is where we start having these tumor cells almost kind of live in harmony with the normal cells. And they kind of can take hold, but at this point, they're not really causing any problems. However, through additional mutations that can occur as the cells replicate more and more, that this small error can become a big error. And that's when something called tumor escape occurs. And this is where the tumor cells now kind of overcome the immune system, or that the immune system is not able to identify and eliminate them anymore. And this is really kind of where some of the areas when we talk about immunoediting with immunotherapy, they talk about the 3 E's. So ideally, you'd like tumor elimination, but sometimes as you have in the middle, you have immune equilibrium and then tumor escape. Many of these immunotherapies are looking at ways that we can potentially go from the tumor escape mode back to equilibrium and ultimately to the tumor elimination. And we'll talk about that a little bit more during this presentation as well. So now this slide is a bit of a technical slide, and I'm not going to go into all of the different items that are listed on the right-hand side of the screen. However, I like this slide because it shows that the tumor really can insulate themselves with different layers of immunosuppression. And I think when you look at this, you can see that it's really not one mechanism that the tumor uses to evade the immune system, but rather many. And I think that this also, as a researcher and a clinician, this helps me understand the fact that generally it's not a single agent that's going to be able to overcome all of these layers. That just like with chemotherapy, where often we use more than one agent, that really we probably need to use more than just one immune agent. And so this is kind of a simplified way of this slide. But again, kind of looking at the tumor as being insulated almost as an onion. And that again, that the immune cells are trying at varying degrees and varying abilities to get through these layers of immunosuppression. And if we're able to allow our immune cells to get through them and allow the immune cells to actually get to the tumor, we may have more of an effect on the tumor than what we're presently having. So to summarize the immune system, so the immune system plays an important role in surveillance and elimination of abnormal cells through a process of immunoediting. These tumor cells are able to insulate themselves with various mechanisms that can help them hide from or help them fatigue the immune system. And it's through natural selection that these tumor cells are able to persist and grow because the immune cells are not able to identify them. So what exactly is immunotherapy? This is a question that I often receive from patients. So these bullet points are actually taken from the NCI page. You can find it at cancer.gov that talks about immunotherapy. And I think this is a great reference for patients because it does break down immunotherapy in a little bit more detail and the specifics of immunotherapy as well. So generally speaking, immunotherapy is a type of cancer treatment that helps your immune system fight cancer. So the immune system, as we talked about, is known to fight cancer cells, just like it actually fights infections and other diseases. In the immune system, there are multiple components, and these include things like white blood cells, different types of organs that are important with the immune system, and then also the lymph nodes that help also fight diseases and infection. And certain immunotherapy can actually help mark these cancer cells so it's easier for the immune system to find them. And they can kind of reignite or boost your immune system in order to allow the immune system to work better against cancer the way that it should work normally. So when we talk about chemotherapy and immunotherapy, there are some differences in terms of targets and other items that are important. So chemotherapy, it targets really the tumor or the environment around the tumor. And this is important, and I'll get to this in a moment, but with chemotherapy, because it is targeting the tumor, that generally once we stop treatment with chemotherapy, we're no longer really treating the tumor. Whereas immunotherapy, it targets the immune system. And with the immunotherapy, what hopes to do is by re-engaging the immune system, that often we can have long-lasting effects that persist well after we stop treatment with immunotherapy. Some of the limitations with chemotherapy are often the side effects. As patients, I'm sure that you're well aware of some of the side effects we see with chemotherapy, like nerve damage, heart failure, low blood counts, loss of hair. And some of these side effects limit either how much chemotherapy we can give or how frequently we can give it. The main limitation with immunotherapy is that we require a working immune system. And I'll talk a little bit about this, but this is important, especially when we think of tumor size or we think of patients who've had multiple prior therapies. We're starting to understand that with immunotherapy, it works best maybe in patients who have had fewer treatments, as well as tumors that are on the smaller size. And again, this is allowing the immune system to do its thing in more of a manageable environment. With chemotherapy, when the tumor evolves in order to avoid being killed by the chemotherapy, often we can have resistance to therapy. A good example of this in breast cancer is we see that often with endocrine therapy, that the tumors actually can become resistant through a mutation in the estrogen receptor, making it that the aromatase inhibitors are not quite as effective. However, with immunotherapy, when the tumor tries to evolve to avoid it, this sometimes can actually provide a new target and a new chance of response for these tumors. Chemotherapy, the onset of the effect is often immediate. So when we start chemotherapy, we can see that the tumors start to shrink relatively quickly. With immunotherapy, it generally needs time. We need time to get the immune system engaged, and so we don't see tumor shrinkage as quickly. And the thing that's also interesting about immunotherapy is that sometimes we can actually see that the response gets better over time. And so with things like vaccine boosters, we can actually see more of a response the longer the patients are on treatment. With chemotherapy, there's no memory response. And so that brings us back to kind of the first point. With the chemotherapy, as we're treating the tumor, then we see the response. But when we stop chemotherapy, often we stop seeing the response. Whereas with immunotherapy, we do generate a memory response in many cases. And again, by engaging the immune system and retraining it to recognize these tumors as bad and as foreign, that we can create a response that lasts long after we finish treatment. Now, one of the requirements for effective immunotherapy is that we have not only a generation of an immune response, but the second one is really that we get the good immune cells actually into the tumor. And this is something that actually has proved to be somewhat difficult. Now, there are many types of immunotherapies, and I'll go through each of these briefly. But kind of the four main categories. One are T-cell checkpoint modulations. So these are different drugs. The FDA ones are currently nivolumab, pembrolizumab, avelumab, durvalumab, ipilimumab. And these are generally either in PD-1, PD-L1, or CTLA-4. But there are current studies going on right now looking at other checkpoint modulators, things looking at OX40, GITR, 41BB, FLAG3. And you can see here that these are all different receptors that we see on the T cell. And so these are different ways to help try to stimulate the immune system. Another type of immunotherapy is T-cell adoptive transfer. And so these are your CAR T cells. These recently have received a lot of press and a lot of discussion in the lay public because of their recent approvals for different types of leukemias. And these have been very promising in the blood tumors, and we're still trying to work to see how we can have them work in solid tumors. But some of the results coming out now are promising with this as well, and we'll discuss that in a little bit. The third group are therapeutic cancer vaccines. There are currently 3 therapeutic cancer vaccines, although none of them are for breast cancer. And these vaccines we'll talk about in a little bit. There's different types of what we call platforms. So these can be viral or bacterial based. They can also rely on a patient's own immune cells called dendritic cells. But these 3 FDA approved vaccine, BCG, Provenge, and TVEC, have made improvements and are promising in terms of helping us kind of augment the immune response. And then finally, the last category that we'll talk about today are effector antibodies and antibody drug conjugates. Antibodies are things like rituximab, bevacizumab, trastuzumab. I'm sure many of you have heard of at least one of those drugs. And the antibody drug conjugate, the one that's right now currently approved in breast cancer, is a drug called Kadcyla, or also known as TDM1. And we'll talk a little bit about that as well. But these are interesting drugs because they not only combine an antibody, but they combine it with chemotherapy or a cytotoxic agent. And we tend to see better responses, but less toxicity. And so all of these are very interesting, both as single agents as well as in combination. And we'll talk a little bit about that in the next few slides. So first we'll start with T-cell immune checkpoints. So what exactly does PD-1, PD-L1, CTLA-4 really mean? Well, as you can see in this picture that I have here on the slide, then in the box on the left, we have the tumor cell, which is the yellow component, and then the T cell, or the immune cell, which is kind of the bluish purple cell that looks like it has kind of little hairy projections. And as you can see, the PD-L1 is on the tumor cell, and the PD-1 receptor is on the T cell. Now what usually can happen is by the PD-L1 on the tumor, this is one of the mechanisms that the tumor cells will express, that they know when they express this PD-L1, that it can bind to the PD-1 receptor on the T cell, and this is where it really inhibits or fatigues that immune cell. So the immune cell is unable to do its job. However, with these immune checkpoints, by blocking either the PD-1, which is on the T cell, or the PD-L1, which is on the tumor, and we have classes of drugs that do both, that you're actually reigniting or kind of waking up the T cell and allowing it to kill the tumor cell. So right now, the checkpoints that are approved in various various cancers, so nivolumab, also known as Opdivo, and pembrolizumab, also known as Keytruda, are both PD-1s. So these are ones that actually bind to the T cell. The PD-L1 drugs that are currently approved are atezolizumab, which is Tecentriq, avelumab, which is Benicio, sorry about that, and then durvalumab, which is Imfinzi. And then also CTLA-4, which I didn't really get into as much, because for breast cancer, we haven't seen as much efficacy or promise as the other two. The current one approved is ipilimumab, which is also known as Yervoy, and that's used in like melanoma. Now, why are these agents exciting? Why do people get excited about these? And so these are a couple of plots, and I know that this is somewhat a little bit more kind of granular detail than probably what's needed. But these spider plots, I think, are really kind of clearly show why we get excited about this. So let me orient you to one of these. So if you look at any of these charts here, you can see that in the middle of the chart on the axis that goes up and down, you can see a 0. And so anything above the 0 is growth of the tumor, and anything that goes below 0 is shrinkage of the tumor. And you can see that in many patients, over a wide range of tumors, that there are certain patients that have a quick shrinkage of their tumors that lasts a very long time. And it's these long-lasting responders are why oncology is so interested in immunotherapy. Because it makes us think, if we can shrink a tumor, or even have a tumor stay the same size and not cause any additional problems, and we can have this last for a long time, is there the potential to change cancer into more of a chronic condition? Just like diabetes or high blood pressure, one that we can live with and physicians can manage, but that's not causing a lot of problems. So next let's talk about CAR T-cell therapy. So CAR stands for chimeric antigen receptor. As I said, this recently had a lot of publicity because in 2017, FDA approved CAR T-cells to treat 2 different types of blood cancers. One is acute leukemia, and the other one was a specific subtypes of non-Hodgkin's lymphoma. Now with CAR T-cells, these are personalized type cancer therapies. So the checkpoints are drugs that can be produced and can be used for many different people, where the CAR T-cell is really specific either to patients. So often with CAR T-cells, what will happen is patients will have blood removed, and we're able to identify the immune cells or the T cells. They go to the lab, and the CAR T-cells are able to be manufactured specifically for tumor-associated antigens that are on those tumors. So something on that tumor that the immune cell has maybe recognized as foreign, but just couldn't destroy on its own. And so the tumor-associated antigen is put inside the CAR T-cell, and the CAR T-cells are able to grow up and multiply. And then all of these hundreds of thousands of millions of cells are now placed back inside the patient. And these CAR T-cells now are able to recognize the cancer and kill them. And this is one of the things that is very exciting about CAR T-cells, because these cells are able to then replicate further within the patient. And usually this is one of the treatments that has been able to give maybe once or twice with really robust responses. This is why the American Society of Clinical Oncology actually named CAR T-cells as the 2018 Advance of the Year. This has really held a lot of promise in the blood tumors. And again, there's a lot of work being done right now in solid tumors like breast cancer. And we'll talk about that in a minute. And so the different tumor-associated antigens that are found within or that can be used in CAR T-cells. So when we look specifically at breast cancer, which is within the red box, there's 4 main ones that the majority of research has been performed on. One is HER2, which, as we know, we have HER2 positive breast cancer and HER2 targeted therapies. And we see HER2 amplification or expression in about 15% of breast cancers. CEA, which is found in about 50% of breast cancers, as well as other types of adenocarcinomas. We have CMET, which is found to have higher expression in tumors that are resistant to trastuzumab or Herceptin, as well as higher expression in triple-negative breast cancers. And then mesothelin, or MSLN, which is found in about 20 to 30% of breast cancers, most of which are triple-negative breast cancers. And so by using these tumor-associated antigens in CAR T-cells, there's multiple studies that are looking at, can we again re-engage the immune system to identify these tumor-associated antigens as foreign. Now, tumor-associated antigens are also used in cancer vaccines. Now, when we think of cancer vaccines, there's really 2 different types. One is preventive, And that includes vaccines like the HPV vaccine or hepatitis B vaccine. And these are vaccines that can, when given prior to the development of cancer, can actually prevent cancer ever from developing. There's also therapeutic cancer vaccines. And these are vaccines that are given to patients who have cancer and that generally can either decrease the size of the tumor or prolong what we call progression-free survival or prolong survival as well in some of these patients. As I said, there's 3 currently approved ones. There's Therasis, which is also known as the BCG vaccine, and this is for non-muscle invasive bladder cancer. And I always like to highlight this one because this was actually initially approved by the FDA in 1990. I think most people feel that immunotherapy is obviously a new and exciting field, but there are many studies that have been going on for 20, 30 years at this point in this field that have laid the foundation for where we're going now. Provenge is a vaccine that's for metastatic prostate cancer, and that was approved in 2010. And then T-VEC was recently approved for melanoma. Now with cancer vaccines, there are multiple different platforms. By platforms, I mean the way that we're able to start generating the immune response. These can be things like peptide vaccines, whole DNA vaccines. These can be dendritic cell, which are often from patients, or they can be viral vectors, bacterial vectors. These are things these are similar to things like the flu vaccine. That would be a viral vector. And often what these do is they contain an antigen or something that the immune system will respond against. This can be things like tumor-associated antigens or tumor-specific antigens. They can also be things like tumor-infiltrating lymphocytes. So again, there's multiple platforms, there's multiple antigens, there's different things we can give along with the vaccines. And I didn't want to go into kind of all the details about this because there's many, many different kind of options for all of these. However, I did want to highlight one of the platforms that my group works with. And it's a very kind of interesting one where we use a viral vector. We use a couple of different ones. One is the adenovirus. Another one is actually, it's similar to the smallpox virus. But has been modified in such a way that it's safe and is not at risk of causing patients to develop smallpox or pass it on. But in that cancer vaccine, we have a tumor-associated antigen. And some of the vaccines, it's 1, some of them it's 2, some of them it's 3 different tumor-associated antigens that we can put in there. And then in this specific platform, it also has co-stimulatory molecules, or ways that we can help stimulate the T cells. And so these vaccines are injected into a patient. And generally, with our group, the vaccines that we work with, we use something called a prime and a boost. So a prime helps stimulate the immune system. Generally, for the viral vector, this is the pox viral vector. And this creates a very, very strong immune response. Now, with a strong immune response, often the immune system can respond and will neutralize it, or basically create ways that kind of take away that immune effect. And so then we have to switch to something called a booster, which is something that can still produce an immune effect. It's just not quite as strong. And so with this, we give a priming dose followed by a boost dose. And the reason that this is advantageous and can be helpful with vaccines is because really you get kind of 3 advantages. So with the priming dose, you get expansion. So we get basically a lot of activated T cells. With the boosting dose, it helps promote memory, which again is important because we want long-lived memory T cells for a long-lived cancer effect. But then also by giving repeated boosting, we get something called antigen cascade. So we find that when we start stimulating the immune system, either with cancer vaccines or other different types of agents, that not only do we get a response against whatever tumor-associated antigen we've addressed in the vaccine or in the CAR T cells, but we tend to start getting more immune responses to other types of antigens. So again, really engaging the immune system. The next type of antibody drug conjugate I want to talk about is TDM1 or Kadcyla. And so these again are kind of an interesting new type of drug. It's almost a hybrid between the monoclonal antibodies and chemotherapy. Now I took these images from the Kadcyla webpage, and I think that they've done an excellent job with kind of breaking this down and clearly showing kind of why these drugs are interesting, but also why they're effective. And so Kadcyla is approved by the FDA for treatment of metastatic HER2-positive breast cancer in patients who've received a taxane, so that would be like paclitaxel or docetaxel and trastuzumab. And so basically Kadcyla goes and attaches to the HER2 receptor on the outside of the cancer cell, just like trastuzumab does. Then what happens is Kadcyla is able to then get into the cell after it binds with that receptor. And then the Kadcyla breaks apart inside the cell and releases that chemotherapy locally in the cell. And this helps to kill the cell. Now, the thing I find very interesting about antibody drug conjugates, with being this hybrid between chemotherapy and kind of immunotherapy, is that you really do kind of get the benefit of both. You get the immune effects of the monoclonal antibody, but you also get the benefit of the chemotherapy with causing quicker kind of death of the cells. And that further can help the immune system identify these cancer cells, and then the immune system will engage and kill more cells. So just to kind of quickly go back over the things that we've covered. So immunotherapy targets the immune system. It requires a working immune system. When there's mutations, this potentially could be a new target. The immune therapy responses are often delayed and can get better, especially with boosters. And there is hopefully a memory response with many of these therapies. Now, a brief review of experiences with immunotherapy and breast cancer. So generally speaking, breast cancer is a cold tumor. And so what does that mean? So hot tumors are tumors like melanoma or bladder cancer or lung cancer that we know have a lot of immune cells in there to start. So remember back when I said the promise of immunotherapy, we not only need a working immune system, but we need the immune cells in the tumor. So in those cases of hot tumors, the immune cells are already there. So giving agents just like checkpoints, so like your nivolumab, your pembrolizumab, that we're going to have responses because the immune cells are already there. However, with breast cancer, when we look at these tumors, there's very few immune cells in breast cancers to start with. And so when we look at all breast cancer subtypes, it's only about 10% of the cells that are there are immune cells. When we look at things with the different subtypes, triple negative breast cancer has the most immune cells, with still only about 20 to 25% of the cells being immune cells. And then hormone receptor positive actually has the fewest immune cells, with only about 5 to 10% of the cells being immune cells. And so why is this important? Well, there have been a lot of large studies that have looked at multiple studies in what we call meta-analyses. And these large studies basically have identified that in triple negative breast cancer and in HER2 positive breast cancer, that patients who have more immune cells in their tumors do better. So they found that for every 10% increase in immune cells, that patients tend to have a better response to neoadjuvant or pre-surgery chemo. They tend to have a decreased risk of relapse, and they tend to have overall survival. And so when we think of these immune cells, also known as tumor-infiltrating lymphocytes, and we think of them in respect to the expression of PD-L1 on the tumors, that when there are more immune cells in the tumor or around the tumor, there's going to be higher expression of PD-L1 from the tumor, because it's the tumor's way of trying to avoid detection by the immune cells. So we can see that these tumor-infiltrating lymphocytes do correlate with the expression of PD-L1, with triple-negative breast cancer having the highest expression of PD-L1, and hormone receptor positive really having the lowest. But when we look even at PD-L1 expression, with triple-negative having the highest, it's still a little bit less than 20% of tumors that have PD-L1 expression. And so it's not surprising that we've seen somewhat underwhelming results when we look at these checkpoints, especially compared to what we've seen in other tumors. So I think that this raises a question to me and to other researchers of, well, if we know that the more immune cells that are in the tumor, the more PD-L1 expression we get, how can we get more immune cells into a breast cancer? And so I'll kind of come back to that question in a few slides, but kind of keep thinking of that as we're going through these next few slides here. So this is just a kind of a quick view of different checkpoints that have been used, and we look at the objective response rates. So how many patients actually have a shrinkage of their tumor of 30% or more? So when we look at the blue bars here, the ones, these are 4 different tumor types that are not breast cancer. And these are 4 different checkpoints that have been approved by FDA. And the plus sign basically means that these are in tumors that have PD-L1 expression. You can see these response rates are actually quite good in terms of patients who are responding, although it's still, you know, the best one is really the microsatellite unstable or microsatellite high colorectal cancer. And that's about 40%. So again, you know, while these checkpoints are very promising in other tumors, they're still not necessarily a home run. Now, when we look at breast cancer, the pink bars are for hormone receptor positive, and you can see those response rates are actually relatively quite low. The avelumab is in HER2, and that's the green bar. And then the gray bars are actually in triple negative breast cancer. And you can see that when it's broken up into the tumors that express PD-L1, we have a little bit better objective response rates. But again, really compared to what we've seen in other tumors, that, you know, these checkpoints as single agents really don't have as much activity as we had hoped. So next we'll move to CAR T-cell experiences in breast cancer. And so our current CAR T-cell tumor-associated antigens, as we already discussed, the established targets are the HER2, CEA, c-Met, and mesothelin. And they're starting to look at newer targets that are listed here. Currently, there's 15 open trials on clinicaltrials.gov. But right now, only early pilot studies have been reported so far saying that these are safe. Really, there hasn't been any clinical responses that have been released to date. So next, to move on to different types of vaccines. So PanVac is one of the vaccines that my group works with. And so this is one of those viral vectors, the smallpox vaccine, that contains tumor-associated antigens CEA and MUC1, and also has those co-stimulatory molecules. Now, PanVac has been around for quite a few years, and they've looked at it as a single agent as well as in combination with chemotherapy like they did in this trial. And again, you can see here that when we look at the progression-free survival chart here, that when we look at the dotted line where it's docetaxel or chemotherapy alone, that the progression-free survival was about 4 months, whereas when we added on the PanVac, the vaccine, to the docetaxel, it actually increased the progression-free survival to about 8 months. And so this was a very small study, and there was no improvement in overall survival. But I think it does start bringing the question as to maybe combinations are really kind of the way to go, that we don't expect to see activity with a single agent, but maybe with combinations we may. And so this is a single patient, and so, you know, this is, I think, one of the things that as a researcher, we use these cases as inspiration, not necessarily as ways to say that this is absolutely going to work, but it makes us think kind of about, again, what can we do that will make this work? And so this was a 32-year-old female. She was diagnosed with triple-positive breast cancer. And unfortunately, she had biopsy-confirmed metastatic disease in her liver shortly after she had her lumpectomy for breast cancer. And she was treated with standard chemotherapy. And she actually had removal of her liver metastasis because it was a single metastasis. And then she had treatment with an aromatase inhibitor as well as trastuzumab. But unfortunately, after a year, she had progression of her cancer in her lymph nodes. So she continued on her trastuzumab and started on our phase 1 trial with PanVac. And as you can see here, she had a rather large lymph node. This is a CAT scan of her chest. So to orient you, you can see her back is on the table. Her breasts are on the top part of the screen. It's almost as if you're looking at her feet. So if you can see, the arrows here are on the right side of her chest, and the side that has no arrows on the left side. But if you can see that lymph node there that I have the arrow pointing to, that over the next 18 months, her lymph nodes really went away. And now at this point, she's been 10 years on our trial and has had no evidence of cancer. And so while this is a single patient, I think that this, for me at least, serves as an inspiration about what type of combinations, what can we use to really help generate that immune response, and not only have the immune response, but get the T cells in the tumor so we can start using these other immunotherapy agents. And recently, there was a new antibody drug conjugate that was just presented at the San Antonio Breast Cancer Symposium this past December, Immuno 132, and this was looking at in triple-negative breast cancer. This is looking at an antibody that targets TROP2. So instead of trastuzumab, which targets HER2, this targets TROP2. And the chemotherapy is the active component of irinotecan, which is another type of chemotherapy we often use in colon cancer. And so the FDA actually gave this drug breakthrough designation in 2016 because in a smaller study, they saw some impressive responses of about 31%. Now, 31% may not necessarily seem a lot, but in triple-negative breast cancer, in this patient population, the standard therapies that we use, the response rates are only about 10 to 15%. And the progression-free survival is only about 2 to 5 months before we have to change to something else. Whereas with this drug, the response lasted about 9.1 months, so basically almost doubled it. And furthermore, we had 9 long-term responders who were progression-free for over a year, and now there's 4 that are progression-free for over 2 years. And so I think, again, this is something, while it's a small study, it's showing good clinical activity as a single agent. And I think, again, it does raise the question in terms of if this is what it does as a single agent, what can we do in combination? And so that leads me to the future of immunotherapy. And so I think there's a couple of different opportunities for immunotherapy in breast cancer. So as I said, first is increasing immune cells, maybe prior to surgery, chemotherapy, or radiation. So again, going back to that data that we know that in certain types, that for every incremental increase in TILs, that we see improved responses and improved outcomes. So what can we do to maybe prime the immune system before we treat with standard of care? What can we do to do that? The second option is perhaps reducing risk of recurrence through engaging the immune system in the adjuvant or kind of post-surgery setting. So this is generally when patients have low tumor volume. Most of their tumor's been removed either through surgery or treated with chemo, radiation. And so if we can engage the immune system at that point, perhaps can we create immune memory? Can we do it so if a metastatic cell starts popping up, that the immune system can identify and destroy it before it can cause a problem? And then the third way is potentially can we resensitize the tumor to chemotherapy in the metastatic setting? So again, with immunotherapy, with targeting the immune system, we do cause mutations. We cause the tumors to mutate and potentially be more recognized by the immune cells, but we also may resensitize the tumors to chemotherapy. And so I think this kind of brings up also the questioning or the question of sequencing. Is it chemotherapy, then immunotherapy? Is it immunotherapy, then chemotherapy? And I think these are all areas in breast cancer and immunotherapy that researchers are actively looking into. So as I've alluded multiple times, I think the future is really combination therapy. And I think that's not just for breast cancer, but for other tumor types as well. We know with single agents that we have some benefit in a small population, about 10 to 20% of patients. And some of those patients even benefit for a long time. But as you can see with combination therapy in this graph, that we can see increased clinical benefit on not only an individual, but a population basis. The one drawback to chemo or to combination treatments is that we can see more side effects. We may see different side effects. But I think the promise of combination therapy is very intriguing, and I think is where the field is going. And it really, what the combination therapy is attempting to answer is, can we make a cold tumor hot? So in an example like melanoma, again, these are tumors that are hot to start with. So when we treat with the checkpoint, we're going to have immediate killing of the cells because the immune system's identifying them. But in tumors like breast cancer or colorectal cancer that are cold, can we use vaccines? Can we use other chemotherapies? Can we use things like radiation to increase the immune cells in the tumor and then treat with the checkpoints to cause tumor cell death and then ultimately memory? Now, standard of care treatments for breast cancer. I think a lot of people think, well, these are cytotoxic agents, meaning they kill the tumor cells. These don't necessarily have immune effects, but they do. We know that radiation has many good immune effects in addition to killing the tumor cells, and there's a lot of ongoing combination trials. As chemotherapy, we know that at normal dosing, or sometimes even at lower than normal doses, that we do see good immune effects with these. We can see this with endocrine therapy, the CDK4/6 inhibitors, so palbociclib, ribociclib. We see these immune effects with trastuzumab or Kadcyla. And all of these right now are being evaluated in combination with immunotherapy agents. These are active clinical trials that are going on. So the future of immunotherapy, again, we need to make breast cancer hot. How do we get more immune cells into the breast tumor? Can we do it through vaccines, through radiation, through chemotherapy? Again, more combinations, looking at the combinations of these different agents. Is that a way we can make these breast cancers hot? And again, as we've kind of alluded to, is that perhaps instead of looking at the metastatic setting where patients have had multiple lines of chemotherapy, can we move it to the adjuvant setting when there's low tumor volume and the immune system is still relatively untouched by chemo? And so there are currently ongoing immunotherapy and chemotherapy trials. There's one that's atezolizumab and Abraxane in triple-negative breast cancer. And this is in patients with 0 to 3 prior treatments. And they've actually seen some impressive response rate of about 38%. This is preliminary data, but you can see that this is much better than what we've seen with the PD-L1 drugs in breast cancer. We've also looked at Pembro and Eribulin, and this is a pretty good response rate at 26%. They're also looking at pembrolizumab and trastuzumab in patients who have already progressed on trastuzumab. And so this is ongoing, but the preliminary response rate of 15 is much better than the 4% that we saw previously with these checkpoints in HER2-positive breast cancer. And then pembrolizumab and abemaciclib in hormone receptor-positive breast cancer. And this is ongoing, but the preliminary data that was presented at San Antonio this past year showed a response rate as well as a disease control rate, meaning the disease is not growing, that was better either than Pembro by itself or the abemaciclib by itself. So again, some promise with these combinations. And so what we've covered is a breast cancer, an overview. We've covered how the immune system fights cancer normally. We've covered what is immunotherapy. We've covered experience with immunotherapy and breast cancer. And we've covered where I think the future of immunotherapy and breast cancer is going. So in summary, breast cancer is a cold tumor. Single immunotherapy drug treatments have not worked well in breast cancer. Earlier treatment with immunotherapy agents may be better, and perhaps sequencing of immunotherapy and chemotherapy may be one of the answers. And combinations of immunotherapy agents and/or standard of care agents are really the future. So I'd like to thank, most importantly, our patients, families, and their friends for participating in research, as well as being active players in the breast cancer community. As a breast oncologist, I find that the input from patients and their families and their friends is extremely important, not only to my clinical practice, but also to the research that I do. I'd also like to acknowledge my bosses here at NCI, Dr. Jeff Schlom and Dr. James Gully, who have been tremendously supportive and encouraging and reviewed these slides. Also, my co-director of the LTIB clinical trials group, Dr. Julia Strauss, Dr. Darren Mays as well, and then my group in the NCI intramural program. So thank you very much for your attention, and I'm open to questions.
Thank you very much, Dr. Gatti-Mays. That was extremely informative and enriching. I would like to begin the Q&A now. Please keep in mind that not all questions submitted will be asked due to the clinical nature of some of them. And if you submitted a question and do not hear it, please feel free to call the Share helpline, and a trained volunteer will be able to help you. You can still submit questions at this time type them into the section on the right side of your screen. First question that came from one of our listeners is there a limit to how much chemo you can have that would eliminate you from immunotherapy treatment?
So each trial is a little different. Some trials do restrict the number of prior therapies that you've had. Some of the other trials, though, do not restrict it. So it really is a trial-by-trial basis. Again, I think in immunotherapy, we are thinking perhaps the earlier the better, just because there's more immune reserve. But I think it really depends on the trials right now, because there is nothing that is FDA approved.
Thank you. Next question. Immunotherapy, for the most part, has been successful in treating melanomas and lung cancers and blood cancers, but not as successful in breast cancer treatment. What makes immunotherapy work well in those situations, and how can we adapt the science to work for breast cancer tumors? Sure. I know you did cover some of that, but if you could summarize again, please.
Sure. So in those tumors where those checkpoints work well to start with, it's because these are tumors that are inflamed or hot to start with. So they have the immune cells actually in the tumor or around the tumor. And as a response of those immune cells being there, those tumors have more PD-L1 expression, which basically just gives more targets for the checkpoints to work. With breast cancer, because we don't have a lot of immune cells in the tumor or around the tumor, I think it's going to be combinations of treatments, whether it's with vaccine or with chemotherapy or with radiation, that we're going to have to use in combination with these checkpoints in order to have as much success as we've had with the other tumors.
Thank you. Last question is, how has Joe Biden's cancer moonshot helped the field of immunotherapy?
Sure. So I think it's helped in a lot of different ways. The moonshot, my group is involved in a couple of the moonshot proposals here, and a lot of the basic science that we do to understanding what actually goes on in the tumor has been largely supported by the moonshot. It is definitely very helpful for that. The other thing that the moonshot has also been helpful for, within breast cancer, obviously there's some more kind of rare types like metaplastic breast cancer, which I didn't really get into, inflammatory breast cancer. And specifically the moonshot has been extremely helpful in looking at ways to treat these rare tumors.
Wonderful, thank you. One more note before we end. There will be a survey at the end of the webinar, and it may take a minute to download, but we'd really appreciate it if you could participate and provide your feedback. And other than that, I would just like to thank Dr. Gatti-Mays for her time and this informative program, and for dedicating your life to researching treatments to breast cancer that is so important to everyone in this room and everybody listening, myself included. So thank you again, everyone, and be well.
Thank you.